All right, and thank you for the introduction. It is a pleasure to be here today as a representative from out of state, and I want to thank the Planning Committee for the invite to come and share our experiences with getting hospitals to report into the National Healthcare Safety Network's antibiotic use option. I don't have any financial disclosures relevant to the content of this, but I do have a confession, and that I am pretty passionate about this topic, and the title of the original presentation was Antibiotic Use and Resistance Module. And then I put these slides together and I emailed Jenna, and I was like, there is no way I can talk for 30 minutes on both the antibiotic use and the antibiotic resistance options. So this presentation does focus primarily on the antibiotic use option. I do have a tiny little bit of information when I talk about requirements about the antibiotic resistance piece. But I am happy to chat further about what that looks like and what we have done in Tennessee with that. So this is kind of what I hope to do with this, was to explain the importance of antibiotic use reporting into the NHSN AUR module, again focusing on the AU piece of that, describe the necessary steps for reporting into the AU option, and then I will show a little bit of the benefits that you can get out of NHSN AU reporting, show what some of those data actually look like, and then show what we've done with some of those data to our reporting facilities and feedback back to them. So the next 3 slides actually are slides that were presented most recently by CDC on the NHSN quarterly antibiotic use users call. So if you are a hospital that already does report, you probably do get this notification from CDC. And this is a quarterly call where they get all of the people who are reporting and kind of show them data, talk about like technical issues that they may be encountering and what solutions that are there for them, et cetera. But they always give kind of like an update on how many reporters do we have. And so right now there's like just shy of 3,000 reporters currently in reporters being a hospital, and this is ever reporter. So if you reported at least 1 month of data, you get counted into this. And then this is kind of what the breakdown actually looks like with regards to hospitals. And I think what I wanted to highlight here is that they have really, really tiny hospitals in here, and then they have very large academic medical centers. And generally speaking, the acute care hospital, the general acute care hospital, does represent the largest number of hospitals that are reporting into the AU option. You saw a version of this slide earlier that kind of shows the cumulative % of facilities that are actually reporting. And I do want to highlight a couple of things on this particular slide. Tennessee was not the first state, but one of the first states to like require reporting, and we're still sitting at like 50% of our hospitals. So I think that's why I have given this talk a bunch since I started working at the Tennessee Department of Health, and at some point I thought, some of the slides in this talk just need to be retired because everybody's going to start reporting. But I think that where we currently are, the relevance of some of these implementation slides really holds true even today as we get into this age of required reporting, which brings me to my next section of the talk, which is why do I have to do this? So in 2018, we have a similar symposium that we put on in Tennessee. And in the early part of 2018, I actually did a kind of similar to Dr. Ashraf's talk, which was, but focusing on the stewardship piece, was like, what are our current updates from the state? What does our stewardship progress look like, et cetera, at that Tennessee version of this symposium. And after the talk, we had a stewardship physician from a large academic medical center, which might or might not be in Nashville, Tennessee, come up to me and tell me, we are not going to be able to do this until somebody tells us that we have to do this. And we really took that. So what we did was we basically told them that they have to do this. We convened a work group to determine if this was even feasible, and so that's where Tennessee's reporting requirement actually comes from, and I have another slide in just a moment about that. But I do want to talk about what there are some nudges to get hospitals to report into the NHSN antibiotic use option, and then we have seen of late a lot more pushes into that direction from federal entities. And so many people in the room have probably seen this. This is the updated version of the core elements that was released in 2019. But I do want to highlight that just last U.S. Antibiotic Awareness Week, CDC came out with what they call priority core elements, which really do highlight that to get the priority core element for tracking, you need to submit data, antibiotic use data, into the National Healthcare Safety Network's antimicrobial use option. And so this is the CDC equivalent of the state health department honor rolls or gold stars, et cetera, is that you get these priority core elements as opposed to just the check mark for achieving each of the individual core elements. Also, very similar to this, but effective as of January of this year, the Joint Commission recently updated their medication management standard that includes the following element of performance: that the antibiotic stewardship program monitors hospitals' antibiotic use by analyzing days of therapy per 1,000 days present, which is the metric that goes into NHSN, or by reporting data into NHSN. Do I think that, I am not a Joint Commission surveyor, but do I think that the Joint Commission is going to come down and like strip you of your accreditation because you have not reported in there? No, I don't. But I think this could be a ding or a red flag that would go on there if there were lots of different red flags. That's going to kind of add to the cumulative number of dings that you would achieve for that. I mentioned that Tennessee actually took that comment from that stewardship physician to heart, and in 2018, so later that year, we announced that Tennessee would require hospitals to report into the antibiotic use option. But we acknowledged, unlike CMS that you'll actually see, that this takes a really, really long time to do sometimes. And so we actually had that the first hospitals, or the largest of hospitals, because our timeline was that we would have this phased-in approach with the largest hospitals going first and then medium-sized and smaller ones, that hospitals would start reporting in 2021, and then the medium-sized in 2022, and then the smallest of hospitals by 2023. And this was announced at the end of 2018. All of those years got delayed by 1 year because of the pandemic, and so we're now in the phase in Tennessee where any hospital that has over 100 licensed beds is required to be reporting. And we are doing a lot of work now with our smaller and critical access hospitals to get them up and running with not only now the Tennessee requirement, which goes live for them January 1st of next year, but also the CMS requirement. And so this is what's pushing a lot of people to start really having these discussions right now, that beginning in calendar year 2024, if your hospital participates in the CMS Promoting Interoperability Program, then antibiotic use and resistance module data are going to be required under the Public Health and Clinical Data Exchange objective. So this applies to all eligible hospitals and all eligible critical access hospitals that participate in that Promoting Interoperability Program, and it does include, as I mentioned, both submission to both AU and AR data. This, I think, is gutsy. I was very surprised to see at least the antibiotic resistance piece included into this, because submitting data into the antibiotic use option involves communication with pharmacy and information technology and infection prevention. Submitting data into the antibiotic resistance option involves kind of take out that pharmacy piece and add like the laboratory piece. So you're dealing with different systems, you're dealing with different people that you need at the table, and it's two entirely separate conversations that oftentimes that may require different information technology support and or I will say surveillance systems, though some of them will do both, a lot of them will do both. And so I think that this is going to be a challenge for many facilities, is to not necessarily do the antibiotic use option piece, but to do the antibiotic resistance option piece. And so there are a couple of things that you should be aware of going forward, that in calendar year 2024, if your hospital participates in promoting interoperability, that you have to either claim a hardship exclusion, which we'll talk about in the next slide, or attest to being in active engagement with NHSN. And you have two options to be in active engagement with NHSN. The first is that you say you're preparing to report and you're validating your data and you're getting it up and running. But you can only claim option number one for 1 year. And so this is kind of your pre-production year. This is your I'm still getting ready year. So technically speaking, you do have until calendar year 2025 to really get up and running with reporting. The other option to be in active engagement is to essentially be submitting continuous days of antibiotic use and resistance data. I do want to just briefly mention, and I will thank Jenna for this particular slide. This is from a slide deck that she actually gave recently, to talk about what that looks like with hardship exceptions. I think this is going to be important for several hospitals, but I don't necessarily recommend that you kind of go down this pathway of always claiming these hardship exceptions, because A, applying for them does not necessarily guarantee acceptance of the hardship, and B, we don't know that those hardship exceptions are going to stay forever, and eventually this exception rule may actually be gone. So really, it's like if you lack the technology, the electronic health record technology, or the internet connectivity, those are the types of exceptions that they will consider. The one that I think, and please do not quote me, but that I envision may actually be considered with regards to antibiotic resistance option is that there's a lot of hospitals that we encounter in Tennessee that are still getting sort of scanned in images of they're small, they're critical access hospitals, but scanned in images of their microbiology reports. And pulling those data into a usable interface to be reported into NHSN is going to be extremely challenging. The link is there in the slide set if you would like to investigate like these exclusions a little bit further. And the one thing that I do want to just mention before I get into like how do I go about doing this, which I think is relevant to a number of hospitals still across the nation, is when the state comes down and kind of requires this of individual facilities, or CMS come down and requires this of facilities, or the Joint Commission comes down and says you need to do this as part of your surveys. It raises a couple of questions with regards to the feasibility of public reporting of antibiotic use and what that means long term. And I want to just mention that I am pro public reporting. There is a little series of publications that are coming out in ASHE over the next couple of months, maybe, about the concepts of public reporting and what that looks like with regards to antibiotic use and whether or not the standardized antibiotic administration ratio is ready for that. And I am on the pro public reporting side. And the reason that I will say that is because I separate public reporting from pay-for-performance measures. And I think that CDC and state public health departments, et cetera, and can utilize these data for meaningful stewardship change across their states and jurisdiction. And that to me is a requirement, or that is part of the public reporting process. I don't think that we are necessarily ready for the pay-for-performance piece of that. And I mentioned that series of kind of publications that are coming out in ASHE. The con one is already published. The pro one is actually not published. I think they kind of, I don't know, I think they weren't, I'm not sure what happened at ASHE, but like they weren't, like that wasn't supposed to happen, and that like the con one was not supposed to come out. But it is very, and I agree with the authors on that particular topic, that it is actually something that I don't think the SAR is necessarily ready for that pay-for-performance piece. But do I think that public health reporting and the use of those data at the state and national levels is important? I do, and so that's why I stand on kind of the public reporting. So all of those regulations I do support, but for more from that quality improvement standpoint as opposed to pay-for-performance standpoint. So how do you go about it? If you have not started this process, I'm going to take you back a little bit further than just antibiotic use reporting into NHSN and describe what things that your stewardship programs could track. So these data actually came from a task force that was designed to assess antimicrobial stewardship metrics, and this was published back in 2017. And what they came out of from this as the recommended metrics for antimicrobial stewardship in general was that there were measures of utilization, and then there were unintended consequence review. And of the measures of utilization, the one that they recommended, this expert panel of stewards, as they call themselves, were that days of therapy, which is the metric that goes into the AU option, and then redundant therapy review were the ones that they recommended to be included. That you can count a lot of things when you go, look into a stewardship program. You can track a lot of different things, but these are the two that have enough data behind them to suggest that they are effective at driving meaningful change in your hospitals and in your facilities. Under the unintended consequences review, again, there's lots of things that you could get, and this also gets into less of your process outcomes and more of your outcome-based research. But MDR pathogen surveillance and C. difficile rates are ones that most facilities are already tracking and do actually have some meaningful utility to the stewardship program. So, which brings us to NHSN. This is NHSN not in all of its glory. This is only highlighting the antimicrobial use and resistance module, which is a piece of the patient safety component of NHSN. So if you have never seen this, the patient safety component within NHSN also houses the device-associated module, which is where all of your CLABSIs and all of your CODIs get reported. It houses the procedure-associated module, which includes all of your surgical site infections, and I mix those up every single time, so I'm glad that I got them right that time. And then it also includes the antimicrobial use and resistance option, module, which I want to talk about this AU option a little bit. This was released back in 2011, and I used to have on this slide voluntary reporting. And I took that off for this particular talk because I feel like we're getting to the point where it is, in Tennessee it is required for most of our hospitals, and we're getting to the point where it is going to be nationally expected of facilities going forward. The purpose of this came when stewards across the nation kind of went to CDC and basically said, we want some way to not only track our antibiotic use, but we really want to be able to benchmark to other facilities that are similar to us that we consider our peers, and that is where not only the AU option was born, but also the standardized antibiotic administration ratio. And CDC through NHS was already equipped to handle that process in as much as they had been tracking things like standardized infection rates, which is a similar metric for HAIs for a while now. And they took a lot of that methodology and applied it to antibiotic use. This is kind of, if you are already reporting, you can take a little bit of a nap, I won't be offended. But I do want to spend a couple of minutes just talking about what the basics of NHSN reporting really looks like, because this is where I was talking about, I feel like I might get to retire some of these slides, but we're still in the phase where people are still needing to hear, what does this look like and what does this mean to me? So the metric that is used for NHSN reporting, and that's not getting into the standardized antibiotic administration ratio yet, or the SAR, is the basic metric is the antimicrobial, the numerator of the metric is the antimicrobial days of therapy over some type of denominator. And there was a little bit of discussion, we'll say, on the ACCP, or the ACCP's IDPRN a few years ago about, is this days of therapy the correct metric for antibiotic use? For better or worse, this is where we have landed. And I'm kind of pro-DOT, but I understand the limitations, I suppose, of the days of therapy, because what you end up counting with days of therapy is the number of days upon which an antibiotic was administered. So this is distinct and different from the number of doses that a patient receives. It is different from what you would refer to as a duration of therapy. So for example, if you have somebody who comes into the hospital and gets a dose of piperacillin and tazobactam at 11:59 p.m. out of their 4 doses that they should have gotten that day, that is considered a day of therapy. Also, if you can sort of flip that and say, and if you have a patient who's receiving an antibiotic every 48 hours and their duration is 7 days, really they will only have received 4 or 3 days of therapy, depending on kind of when you actually started that, because that is kind of what the metric that you're doing is. You're not counting antibiotic use so much as you're counting days upon which antibiotics were given. And so this is, I did, all right. I can remember if I kept these slides actually in here or not, but this actually describes kind of a patient who is admitted to the ICU with ventilator-associated pneumonia and is started on vancomycin and meropenem, and then later is started on amikacin for, quote, dual gram-negative coverage. I won't get into whether or not that was appropriate, but that is what they were started on. And her medication administration record is detailed below. And anytime you see something in green up there, it's actually indicated that the dose was given. Anything in black is scheduled to be given, and then the yellow indicates that stuff was discontinued. So if you wanted to end up counting the days of therapy on this particular patient, you would actually have on this first day, even though those medications were administered very late in the day, they still count as 1 day of therapy for meropenem and 1 day of therapy for vancomycin. On the second day, she would have ended up receiving 1 day of all 3 of those medications. On the third day, she did not receive the dose of amikacin nor the dose of vancomycin. She only received the meropenem, so that's 1 day for that. And then also on the fourth day, even though she received only 1 dose of meropenem, that is still considered a full day of therapy. And so that is kind of the example of what that numerator looks like. And remember, again, you're counting the days upon which those are administered. So the pros of this days of therapy are really this is patient level data, but it's aggregate. So if you go into NHSN, you can't really say, you can't find out who this is. And we get this at the state level a lot, with regards to, can I identify patients? I really can't out of the data that we have access to, which is similar to the way that Nebraska has their NHSN user group. And this is really considered to be the benchmarking standard by which hospitals should be compared. It is, however, difficult to obtain these data without surveillance software system, and we're going to get onto kind of the steps for reporting in just a moment. And then to make sure that this metric is comparable and comparable to other hospitals that you may be interested in seeing, I do need some type of denominator, and the days present is the number of days in which a patient spent any time in a specific unit. The thing that I wanted to highlight with regards to the denominator that is used in the antibiotic use option is that this is distinct if you are an infection preventionist that's worked with NHSN data and HAI data from there for a very long time. This is distinct from patient days. It is only used for antibiotic use data. And it is, actually, I think I did include my example a little bit of what this kind of looks like as well. So for example, if you have this patient who was on the medical ward on this particular day, they will count for the entire day. They will give 1 day's present to the medical ward, and they will give 1 patient days if you're counting at midnight to the medical ward as well. Similar, if you have a patient who is in the ICU, they will give 1 day's present for the ICU and 1 day's present for the medical ward. But then if you have a patient who actually gets transferred out of the ICU and then goes to the medical ward, they will actually give 1 day's present to both of those units, whereas they're only going to give a day's present to the unit on which they're only going to give a patient day to the unit upon which they were when that patient days is actually counted. So right here, they're only going to give they're going to give a day's present to the medical ICU, but they're not going to give one to the patient days to the ICU. And then finally, I think I have a little box that pops up here with regards to I don't know any patient that does this, but if you have someone who actually starts in the ICU, then goes to the step down and ends up on the ward by the end of the day, maybe you have very aggressive transfer systems across your own facilities, but we never had people like this. Again, they're going to receive a day's present for every single one of those units, but again, only a patient day to the unit upon which they are when they actually took the count for those patient days. And then if you sum these up, it's just a count of all of those, you will see that regardless, if you compare your patient days to your days present are going to be more than your patient days, basically every single time. There is a metric for general wards that something like 25-ish to 30% greater is considered the norm for that. But again, every facility is going to be a little bit sort of different with that. So I do want to take the last few minutes. I still have 15 minutes, actually. So I think I have some data in here to show you as well. But I do want to take a couple of moments and talk about the steps for reporting, because I think that's going to be important for you as you go forward and start having these discussions. The one thing that I will add, that I said earlier that this takes time, and I think you should take the time to do this. And you still have time. If you're now just starting to have these conversations, you still have the time to do this. I would say it probably takes, I think the range for most facilities comes out to be anywhere from 6 to 18 months to get this properly vetted and purchase the surveillance system and validated the data and get up and running. Some people can do it in shorter amounts of time. Some people are going to take longer. But I think the average comes out to be about a year's worth of time that it takes to do this. So you still have time even with that CMS requirement in place, but know that this does take a lengthy process, and you should take the time to identify the facility leads for the antibiotic use option. This is going to require a lot of collaboration with infection prevention and antimicrobial stewardship. And then I went ahead and added review unit mapping in NHSN. My number one rule of thumb when I start having conversations with facilities, or facilities are starting to have conversations about this, is that you don't go mucking around with the infection preventionist unit mapping. You will not make friends by doing that. Please don't do it. So, my personal interpretation of this is that if I use an antibiotic in a unit, I would suggest reporting that unit, but every facility is going to be slightly different. But generally speaking, our stewardship teams can fit the unit mapping to their purposes as opposed to the other way around. So you can get the data out of NHSN and you can know what those units look like, and you can find meaningful use out of that by location information once you get kind of up and running with reporting. So do consider reviewing that with your infection preventionist, but I do not suggest necessarily making changes because this unit needs to report antibiotic use in it or not. Obviously, this is going to require a lot of support, and most of the support from hospital administration and pharmacy administration is going to be involving into the next step, which is developing a system for collecting and packaging the data. So you need a method by which you can capture and package the numerator data, which involves electronic medication administration record data or barcode administration medication administration data. And you need a method by which you can package and capture and package all of the denominator data, which involves getting admission, discharge, transfer data. This actually involves usually the purchase of a surveillance software system. And I was happy to see that Nebraska has a reimbursement system, Tennessee does as well, for hospitals that are getting into this process. I would highly encourage all of you to investigate that, whether you're reporting already or not, because that's money that you might be able to get for them. But this is where I see most of those funds actually being used for, is probably with the purchase of the surveillance system. And then do not underestimate the time that it is going to take you to validate these data, which is going to be getting the surveillance system up and running and then pulling data from that surveillance system, pulling your own information technology data about your barcode administration or your EMR, and comparing the two. CDC actually does have guidance documents on implementation validation as well as ongoing or annual validation as well. And I imagine Nebraska can talk you through kind of what that looks like. Call me up. I'm also happy to talk you through what validation actually looks like, but it goes a little bit beyond the scope of this particular talk to do so. So I think I already kind of addressed some of this, but to get this, you have to have the ability to capture the electronic medication administration record and the admission, discharge, transfer data, and to collect and package that data into a standardized format, which is clinical document architecture. And so this is why many folks have to have some type of surveillance system to do this, because it takes a very savvy person, a very savvy information technology person, to package this and to develop your own homegrown system to do this. There are a number of I think I get to that on the next slide. It really provides, and these files must be uploaded these CDA files must be uploaded, and this is what a CDA file looks like. I can't read that. That looks like a bunch of code to me. And so this is the stumbling block that many of our smaller hospitals are running into, is that they're like, I'm working on getting my data. What do I need to do with it? I was like, well, you can't just go into NHSN and say, I used 100 days of Zosyn this month on this unit. You have to put it into NHSN into this file. And so that's where the value of the surveillance system actually comes into play, because you can't just take an Excel file and upload it into NHSN, and you can't just take an Excel file and manually upload data into NHSN. So there are lots, as a state entity, I am very cautious that I do not recommend like one vendor over the other, especially when we are doing a lot of our reimbursement policies. It's very clear that the monies are to be used to help you get up and running with an HSN, but we don't go say you should go find this vendor and buy their product. The two recommendations that I do have regarding finding a vendor are, one, the vendor must undergo antibiotic use synthetic data validation, and CDC has a site that lists all of those vendors. This step essentially means that the CDC sends the vendor like dummy data, they package it, they send it back to CDC, and then CDC says, yeah, it looks good, you're good to go. That's kind of what that process looks like. And the other one is, I do recommend, if you have a vendor that's on that validated list, to consider using one that matches your electronic health record, just for the ease of communication between the two. That's not a requirement, you don't have to do that, but those are my two kind of recommendations that I have to facilities when they call and ask about finding a vendor. There are some vendors out there that have lots of bells and whistles and are very pricey. And there are a lot more that are more economically priced. And it will behoove you to do your research on all of those as you kind of look into that. I think I might skip this because that sort of talks about just the flow of, kind of that, but I think I've gone over kind of a lot of that already. So I want to take the last 10 minutes of this and just chat about what you might get out of reporting. So I stole these slides from NHSN, but I didn't give them credit, so please don't hurt me. But there are lots of different reports that you can go into NHSN and pull, like antibiotic use line list. You can pull SAR line list. They do have a data quality line list that you can go in and look at four very select data quality points to see if you have met a lot of the validation requirements for NHSN. And again, there are bar charts to look at your antibiotic use. There are pie charts to look at your antibiotic use. I am not a huge fan of the outputs from NHSN because I like to get the full line list myself and play with it. The other kind of issue that I have is that we have 60 facilities in Tennessee, and so to pull these data as the bar chart doesn't mean anything. I like to filter and stratify by different facilities and different regions, et cetera. But there's a lot that you can really do with those data. And it doesn't take advanced statistical analysis or programming skills to really play around with the data. It's very clear-cut and straightforward when you download those data out of NHSN. This is some of the data that we recently, one of my junior epidemiologists actually asked if he could do some very basic analysis of our antibiotic use data over the past several years, and I was like, sure, go for it. And so this is kind of data that he put together without a whole lot of direction. I was like, you did well. But this is kind of some of the early things that you might expect to see when you start analyzing. And these are our most commonly used antibiotics, and the trend of each of those antibiotics over time, starting with our first reporting back in 2015. Please note that large increase at the beginning of 2015 to 16 is because we had 3 facilities reporting in 2015, and then we had 15 by 2016 because a large system went live. So I don't think that is necessarily a huge increase. It was just because of the number of facilities wasn't very well represented that early on. This is one of the things that he highlighted to me and I thought was very interesting. This is 2020, and that red line at the top actually is ceftriaxone, and that green line kind of down at the bottom is azithromycin, and both had a bump in 2020, which was representative and actually jives a lot with the national data that we saw with inpatient use overall of increased ceftriaxone and azithromycin from people coming into the hospital with COVID and get started on community-acquired pneumonia medications. This is something that we in Tennessee have recently, and by recently I mean as of last week, have put together for our facilities. And so we have developed what we call our quarterly SAR report, where we actually this is antibiotic use rates. I apologize. This is it's on the next slide. The SAR report. So this is internal data. We have not necessarily published these particular data, but we are starting to analyze. I've been very hesitant to report publicly any of our antibiotic use data because of the number of facilities that we had reporting, but I'm now up to roughly 60 or so. So I'm feeling much more comfortable. We're working on a manuscript of these data. And this is actually, I think, an image that they are going to include in that particular manuscript, but it really just shows a lot of each individual diamond on this is a hospital arranged by bed size and what their antibiotic use rate over that entire time frame was. We have a couple of outliers on that small side, and I think that's, I know really that bottom outlier is a psychiatric hospital, which doesn't use a lot, and so, but I think the other ones warrant a little bit more investigation. And then finally, I will just mention this is the big and sexy thing that everybody wanted out of the NHSN module, which was the standardized antimicrobial administration ratio, and this is a risk-adjusted metric of antibiotic use. That if you're familiar with SIRs, it's very similar. It compares your predicted antibiotic use or your predicted days of antimicrobial use to your observed antibiotic days, or I guess the other way around, technically speaking. And this is the metric that was created to benchmark facilities. One of the very first questions that I think I ever had asked me when I started working at the Department of Health was, I have my data, how do I calculate my own SAR? And I was like, well, you don't. Because at the time, CDC had not actually released the model that showed they had at least told us kind of the variables that were in there, but they hadn't given us any of the details of what that model really looked like to predict the days of therapy. And so they have recently released that information. And these are kind of all of the variables that go into the predicted days of therapy, because the SAR itself is kind of easy once you kind of get that predicted days of therapy. And so this is what your SAR report actually looks like directly out of NHSN. It will show you your antimicrobial days, and it will show you your predicted use. And then really it just kind of divides the two together, and then helps to kind of determine what your SAR actually really is. The thing that I will add is about the SAR is that we are getting to the point where I don't know that this is necessarily true anymore, but we found very early people, when they were early adopters of the antibiotic use option, they would get their SAR and they'd be very disappointed because, again, the SAR is based on early adopters of the NHSN AU option data, which was... I guess this is okay to say. It was basically all of the VA's hospitals and all of those hospitals in Utah, Julie. And so these are programs that really had very strong stewardship programs, and so these are the metric by which you were being compared to, were these facilities with very strong stewardship programs. And I think we have improved that with the recently-ish rebaseline of the SAR back in 2017 and then 2019 to add the neonates. But the thing about the SAR is that having a higher SAR greater than 1 essentially may indicate excessive use of antibiotics. Having a low SAR may indicate underuse of antibiotics, and this is a distinct difference from, let's say, something like the SIR, where we could get to a goal of 0 for an SIR, but we are never going to get to it. We're never going to use no antibiotics. And so the SAR is not a measure of appropriateness. It's not a measure of judicious antibiotic use. But if you do have an excessively high or low SAR, that does warrant further investigation. There are a bunch of different SARs, and the thing to kind of think about with regards to SARs is that they are aggregate of a lot of different antimicrobials. They are not just one drug with one exception in pediatrics, which is azithromycin. So there's like a SAR for all antibacterial agents for select units. There's a SAR for broad spectrum antibiotic agents that are predominantly used for hospital onset infections. So these are a bunch of different like drugs thrown into this. Eventually, people keep saying, I want a SAR for this, or I want a SAR for that. And the CDC can't do that until more data for all of those individual agents and all those individual units might actually get in there. So do I think the SARs will expand? Yes, I do. Do I know how they're going to expand? No, I don't. But right now, this is kind of what we have to work with. And then this is kind of what our SARs look like in Tennessee. We have a huge, where's MRSA on here? So we don't have the same surgical site infection like issues that were described earlier with Nebraska. We have a huge problem with MRSA. And so our gram-positive SARs are historically higher than one across the state, whereas like some of our other ones might be lower. The thing that I do think is kind of interesting is the narrow spectrum beta-lactam SAR up here, which is one that we would want to be higher than one, is actually much lower than one. And then this is the report that I am giving to hospitals as of last week, which is essentially all of the hospitals that are reporting, and then each of the hospitals will know who they are. So like hospital will know I am hospital BA, and this is kind of my SAR, but I don't know, I know what all the other small and medium-sized hospitals are, but I don't know kind of like who they are. And this is something that we have started to do as of last week, and we will kind of continue to do this for a couple of quarters, and then we'll elicit some feedback from our stewards across the state to see what they think and ways that we can improve upon this. This is my last slide. It's just where to find more information about the NHSN antibiotic use and resistance option. And I am also happy to kind of honor any questions about this at the time in the 19 seconds that I have remaining. So I appreciate your time and attention, and thank you all very much.
On the promoting interoperability component,
Yeah.
particularly for small hospitals, can you describe the patient population that's required? And will NHSN accept that limited patient population that matches the promoting interoperability population?
So I honestly don't know that has been broken down into whether or not that patient population. I don't, but I have several hospitals that in Tennessee that are very small and are critical access that have been within the promoting interoperability, previously meaningful use, and they've been kind of accepting those data for a while. So I have no reason to believe otherwise that NHSN or promoting interoperability would not be interested in those data despite the change in patient population. Any other questions? All right. Well, thank you all again for your time and attention. And it has been nice to be here in Nebraska for my first time.